Okay, hi everyone. I'm Malak Hassan. I'm a second year medical student. And today I'm going to be teaching you guys about the thyroid gland and its control mechanism and its function. So let's get started. And here are my contact details. Can you guys see my pointer before we start? Okay. Here are my contact details if you need to ask me any questions. And I'll have some checkpoints in the middle. So if you do have any questions throughout, please feel free to write in the chat or even turn on your microphone and speak. I love when things are interactive. So yeah, let's get started. So we're going to start off with the objectives. First, we're going to review the histology of the thyroid gland because that's integral to your understanding of the control mechanism and the function of the thyroid gland. And then we're going to discuss the hormones that are released by the thyroid gland. And then we're going to talk about how they're produced. And then we're going to talk about plasma concentration of T3 and T4 and discuss peripheral conversion of T4. And then more things. And towards the end, we'll have clinical syndromes and questions. So now let's get started with the thyroid histology. So here, as you can see in this picture, you have the follicles of the thyroid. And the follicles of the thyroid follicles are actually the major functional unit of the thyroid gland. And basically they're made up of follicular cells. So if you can see my pointer, I'm pointing at these follicular cells. And within the follicular lumen, so the lumen of the follicle, you'll have some thyroid colloid. And this thyroid colloid will be responsible for containing basically the precursors of thyroid hormone, which are thyroglobulin, and we call it, in other words, thyroid colloid. And it's important to note that the size of these cells will change. It's dynamic. Why? Because these cells, depending on the activity of the thyroid gland, so whether the thyroid gland is releasing lots of hormone or less thyroid hormone, they'll change size. So when the thyroid gland's activity is increased, you're going to have larger cells, and therefore the lumen of the thyroid lumen is going to be bigger. Okay. In addition to the thyroid cells, we have parafollicular cells. I'm not sure if I can point them out but just trust me that when I say they're between the follicles. And these parafollicular cells, or the C cells, they're basically scattered in between the follicles, and they're responsible for secreting a hormone called calcitonin, which is involved in decreasing calcium levels. But that's not related to the thyroid function itself. It's more related to the parathyroid gland. So for now, I just want you to focus on the thyroid follicles, the follicular cells, and the colloid that's found inside the lumen. Now let's talk about the thyroid hormones. What are the thyroid hormones? Well, your thyroid basically secretes T3 and T4, which are two thyroid hormones that are made up of tyrosine residues. As you can see here, this is the tyrosine molecule. Here it has tyrosine and another ring attached to it. It's a phenyl ring. And it has iodine onto it. Now, whether it's T3 or T4 will depend on how many iodines there are on the molecule. So T4, which is tetraiodothyronine, so tetra, 4 iodoiodine, so 4 iodines on the thyrine molecule. So that's, you can see, oops. Okay, you can see that there's 4 iodine molecules. And on triiodothyronine, which is T3, you have 3 iodoiodine thyrine. So 3 iodines on here. And you also have reverse T3, which is an inactive form of T3, but we're going to discuss that later. But for now, I want you just to know that you don't have to know the structure. It's just to help you visualize it better and understand it better, that your thyroid secretes T3 and T4. T3 has 3 iodines, T4 has 4 iodines, hence the name. And they do the exact same job, but they do them at different capacities. But what does that mean? It just means they carry out the exact same functions. But T3 is way more potent than T4, and it's way faster at doing its job. And that's why the thyroid produces less of this hormone. Now, the issue is iodine is needed to produce T3 and T4. So in some parts of the world, there is a deficiency in iodine because they don't get it in their diet. Usually you get iodine from your diet. And if there's a deficiency in iodine, then you have basically deficiency in T3 and T4. All right. But now let's talk about the proportions of T3 to T4. The thyroid will secrete more T4, so it's 90% as compared to T3, which is only 10%. And now let's talk about the hormone synthesis. So where does the hormone synthesis happen? Well, obviously in the thyroid, but where in the thyroid? It happens in the follicles of the thyroid, the ones I showed you on the histology slide, and inside the follicular cells, so within the cells themselves, and within the follicular lumen. Okay, so I've divided the steps of hormone synthesis into the ones that are inside the cells and the ones that are inside the lumen, just to help you visualize it better. Inside the cells, you have the signaling. So once TSH binds onto the thyroid cell receptors, it's going to activate some signaling pathways, and it's going to initiate the production of thyroid hormone. And then you have thyroglobulin synthesis, which also happens inside the cells, and then thyroglobulin is released into the lumen. And then you have iodine trapping, because it makes sense. You need iodine to make thyroid hormones, and therefore you need iodine. You need to trap iodine into the follicles. Now, this is what happens inside the cells. As for what happens inside the follicular lumen, you have 3 steps: oxidation, organification, and coupling, and we're going to talk about those later. So now that we've established the steps and where hormone synthesis occurs, what do we need for thyroid hormone synthesis? Well, it's really simple. All you need is iodine, and thyroglobulin. And you also need one enzyme, which is called peroxidase. And I like to call this the clownzyme, and you'll see why later I call it the clownzyme. It's a pretty lame joke, but I think it helps you remember it. So let's move on to the next step. First, let's talk about iodine before we get into the actual synthesis of hormones. Where do we get iodine? Well, like I said, we get it from the diet, and you need about 1 milligram per week to synthesize all the T4 and T3 that your body needs. And iodine is basically absorbed by your intestines in the exact same way that chloride is. So it enters your bloodstream, then it's taken to the thyroid gland, and then it gets trapped, and so on. And again, we're still going to talk about the steps. This is just to give you a brief introduction. What about thyroglobulin? What is thyroglobulin? Basically, thyroglobulin, remember how I showed you the histology slide here, where you have the lumen of the follicle and you have thyroid colloid, or in other words, thyroglobulin inside. It's basically just a glycoprotein that has a bunch of iodines on it. Okay, so glycoprotein with 2 chains, you don't have to know this, but because it wasn't in your slides, but it's just there for the sake of your understanding. It's made up of 2 chains, and each chain has 67 tyrosine molecules. So you can imagine how many T3s and T4s can be made out of each tyrosine molecule, right? And this thyroglobulin is synthesized inside your follicular cells, and then it's sent into the follicular lumen. Oops. Okay, I have a checkpoint here. If you have any questions, please let me know. Please feel free to ask either in the chat or open your mic. I like this to be as interactive as possible.
No questions.
No questions. Okay, that's great. Okay, so this was just basically an introduction, like a warm-up before we get into the actual physiology. So let's get started. Now we're going to talk about the steps of hormone synthesis, for real this time. So what are the steps of formation? These are the steps that we're going to I'm going to walk you through. So you're going to have the HPT access, and then iodine trapping, peroxidase, which is going to do oxidation, organification, and coupling. And then we're going to have endocytosis of thyroglobulin, lysosomal cleavage of T3 and T4, and recycling of MIT and deiodinase, and then transport. So it's a whole long process, but trust me, it's really easy once you understand it. So let's get started. Okay, so step 1, you have the HPT access. And the HPT access, it can seem like it's something intimidating at first, but it's actually pretty simple. All I want you to think of is to think of the hypothalamus as the big boss. The big boss, the one that's sending all the signals to the pituitary, who's the secretary. And then the secretary sends off the signals to all of the workers, like the thyroid and other glands in your body. So the big boss, the hypothalamus, is going to secrete a hormone called TRH, or thyrotropin releasing hormone. Okay. This thyrotropin releasing hormone is going to go act on the pituitary, specifically the anterior pituitary, and it's going to get there via some blood vessels we call the hypothalamic hypophyseal portal system. And it sounds like a complicated name, but I swear it's not. It's just a set of blood vessels between the hypothalamus and the hypophysis. And the hypophysis is just another fancy word for the anterior pituitary, for the pituitary gland in general. So in this case, we're talking about the adenohypophysis, hypophysis, or the glandular part of the hypophysis, so the anterior pituitary gland. So the hypothalamus is going to secrete TRH. TRH is going to go stimulate the pituitary gland, and then it'll when it binds onto its receptor, which is a GQ receptor, again, you don't really have to know this, but it's just there for the sake of completion. It's going to bind onto its receptor, and then it's going to stimulate the pituitary gland to release TSH from the anterior pituitary all the way into the blood. Then it releases it into the blood. It travels all the way to the thyroid gland. It'll bind onto its G protein receptor in the thyroid gland, and it'll act via two mechanisms in order to help synthesize and release T3 and T4. Okay, so from the word HPT axis, I just realized I didn't exactly explain what the abbreviation stands for, but HPT is hypothalamic pituitary thyroid axis. Okay, so from the hypothalamus to the pituitary to the thyroid gland. Now let's talk about we're still in step 1, but I'm going to talk about how TSH carries out its functions. So TSH, which comes from the anterior pituitary gland, coming from the blood capillary. Here, I've drawn my own diagram here because I feel like it's easier to understand when it's step by step rather than when you have all the steps in front of you. So I drew my own diagram, and I'm going to be explaining through it, and then I'll take Dr. Simon's diagram and I'll explain the steps on that later, just as like a quick review. So here you have the TSH coming from the blood, and it's going to bind onto its receptor. And then it's going to act via two mechanisms, cyclic AMP and DAG. So it's going to activate adenylyl cyclase and phospholipase C. So when it activates cyclic AMP, it's going to go and stimulate the rough endoplasmic reticulum to produce thyroglobulin. Because remember, it was a glycoprotein, and we're a protein synthesized in the rough ER. So they're going to go to the rough ER, and then they're going to be synthesized. And then they're going to be packaged up and sent to the Golgi, where they're modified and packaged, and then they're going to be sent off into the cytoplasm as thyroglobulin. Now, this thyroglobulin is going to be released into the follicular lumen across the apical membrane. So here you have the apical membrane, which is facing towards the lumen, and here you have the basolateral membrane, which is facing towards the blood. So this is the pathway of cyclic AMP. Again, you don't need to know the exact pathway, you just need to know what it does. Okay, then you have the phospholipase C. It will activate PKC, and then PKC will go and phosphorylate or activate our little cute enzyme peroxidase, our clanzyme. And again, we're going to discuss what the functions of peroxidase are when we get there, but I just want you to know for now that TSH, and then okay. I want you to know that TSH will bind onto the receptor, and then it'll activate the production of thyroglobulin in the rough ER, and will stimulate the production of, or like the expression of, peroxidase enzyme. It's through the cyclic AMP, it's also going to do another thing, and it's going to stimulate the NIS symporter, and it's going to stimulate the next step of iodine trapping. Next, we have the second step, which is iodine trapping. Oops. Okay, so here on the basolateral membrane, you're going to have an NAI symporter, or we call it, in other words, we call it an NIS protein. And what it's going to do is that it's going to take sodium and iodine at the same time and push them inside the follicular cell from the blood. So sodium and iodine from the blood into the cell. And then if you can see here, I have a really tiny channel here. It's a sodium potassium ATPase. And this sodium potassium ATPase, all it does is that it pushes sodium back into the blood. And what this does is that it maintains a concentration gradient of sodium so that sodium can continuously be transported in, pulling along with it iodine. And this is what we call secondary active transport. So the purpose of iodine trapping is to increase the level of iodine 30 to 250 times more than the blood, depending on how much thyroid hormone that your body needs. So on the apical membrane, which is on this side, facing towards the lumen, the pendrin transporter, it's going to start doing basically an exchange. So it's going to exchange iodine that came in from the NIS protein, and it's going to push it all the way into the follicular lumen. And then it's going to pull in chloride with it. So it's important to remember that 2 sodiums, I didn't draw it on the diagram, but 2 sodiums for every iodine are symported into the follicular cell on the basolateral membrane, and 1 chloride is pulled into the cell in exchange for 1 iodide out into the follicular lumen. Now, I want to mention that NIS is very highly expressed in the thyroid gland, but it's also found in other places, for example, in the placenta, the salivary glands, actively lactating breast. I'm just saying this because Dr. Simon mentioned it in his lecture, but I don't think it's that important. And another point that I want to mention is that if you have a low level of iodine, so say your body already, you're not taking in enough iodine in your diet. So logically, what's going to happen is that your body's going to try to pull out as much iodine as it can from your blood to push it into your follicular cell, into your follicular lumen, in order to make thyroid hormone, right? So when you have depleted levels of iodine, your NIS protein is going to be increased. It's going to be more expressed than if there was a normal level, okay? So like we said, NIS will take in sodium and iodide by secondary transport. Here you can see the sodium potassium ATPase, and it's going to bring iodine into the follicular cell, and then it's going to push it out through the pendrin transporter, and that's your step 2, called iodine trapping. Next, we have step 3, 4, and 5, which are done by peroxidase and our cute little clownzyme. And I call him the clown for 2 reasons. Basically, this clownzyme, he juggles 3 reactions, and he likes to say ook. So the 3 reactions are basically ook: oxidation, organification, and coupling. So let's get started. Let's talk about thyroid peroxidase. Now, I zoomed in on the picture so that you can see it more clearly, but peroxidase here, what it does is that it puts 2 iodides together and forms an iodine molecule, so an I2. And how it does this is that it removes an electron, so it oxidizes them. This is called oxidation. This is the first step. And there's another enzyme that's involved in this process called dual oxidase, and dual oxidase is going to produce hydrogen peroxide, or H2O2. And that's going to act as the electron acceptor. So when you remove the electron from the iodine molecule, the molecule that's going to accept that electron is H2O2. So that's the electron acceptor. Next, we have the process of organification. And basically, you're organifying I2. Iodine in and of itself is not an organic molecule. So when you're, it's not an organic molecule, so it's an inorganic molecule. When you take it and you attach it to an organic molecule, like thyroglobulin, you're going to be organifying it, okay? So that's where the name comes from. So we said oxidation, and now organification. So you're organifying I2, you're attaching it to thyroglobulin. And what you're going to do is that you're going to attach it onto the tyrosine residue. I'm not sure why it's not clear, but here you have thyrine, which is the tyrosine residues, and you're going to attach iodine onto it. If you attach 1 iodine, okay, as you can see here, you're going to produce something called MIT. What's MIT? monoiodothyronine. Mono, 1, iodo, iodine, thyrine, tyrosine residue. And then here, if you attach 2 instead of 1, you're going to have diiodothyronine. So diiodothyronine is 2 iodines per thyrine molecule. So what peroxidase does is, number 1, it oxidizes. So it oxidizes iodide into iodine by removing 1 electron, and dual oxidase is going to contribute by making hydrogen peroxide, and this hydrogen peroxide is going to act as the electron acceptor. All right. After that, you're going to have organification. So you're going to take that iodine molecule and you're going to throw it onto thyroglobulin. And when you throw it onto thyroglobulin, you're going to form 2 things. You're going to form MIT if you add 1 iodine molecule, and you're going to form DIT if you add 2 iodine molecules. Okay, I hope that's clear. And feel free to interrupt me at any time if you have any questions. Then step 5 of peroxidase. So the third step that's carried out by peroxidase is coupling. And coupling is simply just quick maths. All you have to do is add 2 and 2 together, so you'll get 4. So DIT plus DIT, you can see I've drawn it here. Here's your MIT, here's your DIT. So if you take 2 DITs and you add them together, you're going to have tetraiodothyronine. So diiodo equals tetraiodo, and that's going to be your T4. And in other words, that's also called thyroxine. And if you add 1 plus 2, it gives you 3. So MIT plus DIT is T3, or triiodothyronine. It's a very simple step. Now, let's talk about the final steps that we have for thyroid hormone synthesis. Basically, your colloid, the thyroglobulin, the iodine, the iodinated version of it, is going to be endocytosed. So it's going to come in by endocytosis back into the follicular cell. And what's going to happen is that it's going to be cleaved by lysosomes. So the lysosomes are going to fuse with the endocytosed vesicle, and then they're going to basically hydrolyze the T3 and T4 and release them from the thyroglobulin molecule. And this happens on the apical membrane, and then is going to move all the way into the blood capillary by a transporter called the MCT8 and the MCT10 transporter, or in other words, the monocarboxylate transporters MCT10 and MCT8. And basically, anything else that's left that has not been coupled or paired together of iodinated tyrosine, so monoiodotyrosine and thyrine, I made a mistake here. Monoiodothyronine and diiodothyronine, those are going to be endocytosed, and then they're going to be recycled. So they're going to be broken down by an enzyme called iodotyrosine deiodinase. And this deiodinase is specific for MIT and DIT. So it's not going to break down T3 or T4. Okay, so the sum of the iodinated tyrosine is going to be broken down by iodotyrosine deiodinase. The name is very difficult to say. And like we said, they cross over into the MCT8 channel. So this is the diagram that Dr. Simon has inside his PowerPoint. So let's go over that real quickly. First, you're going to have the HPT axis. So TSH will bind onto its GS and GQ, and it's going to stimulate the production of thyroglobulin in the ER, packaged in the Golgi, and then it's going to be secreted out into the follicular lumen. And then you're also going to have the stimulation of sodium iodide symporter. So sodium is going to come in, iodide is also going to come in. And iodine is going to continue throughout the follicular lumen. It's going to move all the way to the apical membrane. It's going to be transported by pendrin all the way into the apical membrane. So now you have thyroglobulin and you have iodine. Now you put them together. So, but first there's a step that we're missing. It's oxidation. So oxidation via dual oxidase is going to produce H2O2, and thyroid peroxidase is going to take two iodines, put them together, remove an electron, and give it to hydrogen peroxide, and it's going to produce an I2 molecule. So that's the process of oxidation. Then you have organification. So you're going to take the I2 and you're going to add it onto thyroglobulin. So you're going to make MIT and DIT. And then that's the process of organification. Then you're going to take MIT and DIT and you're going to add them together. So MIT and DIT will give you T3, and two DITs together will give you T4. And that's the process of coupling. After that, it's going to be the thyroglobulin molecule is going to be endocytosed all the way inside the follicular cell. And after that, it's going to fuse with a lysosome. And that lysosome has proteolytic enzymes, which are going to break down the thyroglobulin molecule and release MIT and DIT and T3 and T4. So the T3 and T4 are going to exit out of the follicular cell back into the blood via MCT8 and MCT10. And the MIT and DIT are going to be recycled into by iodotyrosine deiodinase to make iodine available again for more production of thyroid hormones. And then after that, T3 and T4 are going to bind onto a thyroid binding globulin, which is basically just a protein carrier. It's like a car. Those thyroid hormones, they bind on, and then they're going to be transported in the blood to the area that they're going to be acting on. Now, I have another checkpoint here. Does anybody have any questions? I love cats, by the way. I don't know if you can tell.
All clear.
All clear? No questions?
Yep.
Okay, that's wonderful. Well, feel free to ask questions. I don't bite. Okay. Why isn't it moving? Okay, there it is. Okay, so plasma binding. Now, we said that T3 and T4 are going to circulate in the bloodstream, almost entirely bound to proteins. So they're going to bind on to two main proteins, TBG, which is thyroxine binding globulin, and transthyretin. TBG is the major binding protein, and it's basically made in the liver, and it binds one molecule of either T4 or T3, and it binds around 70% of the circulating T4 and T3. And transthyretin will bind around 10 to 15%. Albumin, which is another protein that's synthesized in the liver, it's another plasma protein. It's going to bind 15 to 20%, and lipoproteins will bind another 3%. Now, the difference between T3 and T4 is that T4, only 0.02% of T4 exists in the free state, whereas 0.3 of total plasma T3 exists in the free state, which means that they're not bound to proteins. That basically tells you that there's more free T3. So this free T3, more of it, and it's also more biologically active, it's more reactive. It's going to mediate the effects of the thyroid hormone more than T4 on the peripheral tissues. And free T3 will also exert negative feedback on the pituitary and the hypothalamus. So if I go back to this picture here, you can see here that the TRH secreted by the hypothalamus will go bind onto the pituitary, TSH, and then it'll release T3 and T4. T3 and T4 are going to go and inhibit the anterior pituitary and inhibit the hypothalamus, so that's going to be negative feedback. Okay, I hope that's clear. Okay. Now, in the case that there's something called an MCT8 deficiency, remember what MCT8 was? MCT8 was the channel that was responsible for taking T3 and T4 out from the follicular cell into the blood. So if there's an MCT8 deficiency due to a rare genetic disorder or a genetic mutation, It's going to lead to a severe condition known as Allen-Herndon-Dudley syndrome. It's a mouthful. Allen-Herndon-Dudley syndrome, or AHDS. And basically what this effect it has is that it affects the child's cognition, mobility, and overall health. And these effects are caused by not enough thyroid hormone being produced. And it's, as you'll see later on, that the CNS, the brain, it requires normal levels of thyroid hormone in order to develop properly. So in individuals who have AHDS, they don't have the channel that allows them to remove the thyroid hormone from the thyroid to the blood and from the blood into the brain, and because they have a defect in the thyroid hormone transporter MCT8. So this causes neurological deficits. It causes them to have a problem in cognition, mobility, and overall health. Now let's talk about the transport of T3 and T4. Now it's important to note that changes in thyroid binding globulin, or TBG, will significantly affect the total plasma T4 and T3 levels. And TBG will maintain a large circulating reservoir of T4 that will buffer for any changes that happen in thyroid gland function. So if, for example, the thyroid gland activity increases all of a sudden, the TBG is going to be there to bind on to any extra thyroid hormone that's being synthesized. And that's going to maintain the level of the thyroid hormone at a decent level. However, if the thyroid hormone is not doing its job, it's not secreting enough, so that the production of the thyroid gland decreases, then TBG will also be there binding onto T3 and T4. That's going to cause it to release any reservoirs that it has in order to maintain a good and stable level of thyroid hormone. Now, the binding, sorry, give me a second. The binding of plasma T3 and T4 to proteins, it also helps to prevent the loss of hormone molecules in urine, and it helps to conserve iodine. So basically, remember how in renal, proteins cannot cross the glomerulus? So since they cannot cross, if hormones are bound to albumin, if they're bound to TBG, to transthyretin, what this is gonna allow is that it's gonna prevent the loss of hormones in the urine, and it helps to conserve the iodine. Now, it's also important to note that the half-life of T3 and T4 is different. So the half-life of T4 is about a week, and T3 is only 1 day, because T3 is more active. You can think of it as like more unstable, it does its job faster, you know? Now, Dr. Simon also mentioned that transthyretin will transport T4 or thyroxine in CSF, and it'll provide thyroid hormones to the CNS. Now, it's also important to note the normal ranges. I'm not sure if you're required to know these or not, but T4 is between 77 to 155, and T3 is between 1.1 to 1.2 to 2.8, and TSH is between 0.2 to 4. Now, if there are levels of hormones that are above or below the normal range, this is going to indicate a problem with the thyroid, either hyperthyroidism if they're higher, if the levels of T3 and T4 are higher, or hypothyroidism if the levels of T3 and T4 are lower. Now let's talk about peripheral conversion. We said that T3 is the more active version, the more active form of thyroid hormone, and it's the form that carries out most of the functions in the peripheral tissues. So obviously we're going to have to convert T4 into T3 in the peripheral tissues in order to carry out the functions that we need to carry out, right? So how we're going to do this is via type 1 deiodinase, or a group of deiodinases. And in organs that receive lots of blood supply, like the liver and the kidneys, you're going to have type 1 deiodinase. And this process will allow you to increase levels of T3 in the blood and to supply circulating T3 for uptake by other tissues which don't have local T3 deiodinase enzymes to generate T3 in their own tissues. So if it's low or absent in other tissues, basically what happens in the liver and the kidneys is that it circulates T3 for other tissues. Now, the primary product of the thyroid gland is T4, which we said was 90% and 10% was only T3. Now, in the brain is a special tissue. It'll have its own deiodinase, which is called type 2 deiodinase. And basically, it'll help the brain maintain its own levels of constant intracellular levels of T3 by this type 2 deiodinase. And it's found in the glial cells of the CNS. The glial cells are like the supporting cells of the central nervous system. And they're going to be like expressing type 2 deiodinase or D2. And it'll have a very high affinity and it'll help to maintain concentrations of T3, even if you don't have enough T4 in the blood due to hypothyroidism. Now, remember how we said the brain has it's like a really important organ and it requires lots of thyroid hormone. So type 2 deiodinase makes sure that the brain always has constant levels of T3. Now let's talk about the functions of the thyroid. So I've summarized it by something called the 6 Bs. So the functions of the thyroid hormones are brain maturation. So without it, babies might have a condition called cretinism, and we're going to talk about that later. It's also important for bone growth, and it synergizes with growth hormone. So thyroid hormone and growth hormone are going to work together in order to allow bone growth. It also has beta adrenergic effects, so it increases beta receptors in the heart. So it increases cardiac output, heart rates, stroke volume, contractility. Beta blockers will help to alleviate adrenergic symptoms in something called thyrotoxicosis, which we're also going to discuss later. But thyrotoxicosis simply means that you have increased levels of thyroid hormone to a level that's toxic to the patient. Also, one of the thyroid functions is the basal metabolic rate, or the BMR. So it's going to increase because sodium potassium ATPase activity is also going to increase. It's also going to increase oxygen consumption, respiratory rate at rest, and body temperature. And it's also going to increase the blood sugar, so increasing glycogenolysis and gluconeogenesis. Remember, gluconeogenesis is forming new glucose using other substrates. And glycogenolysis, the names are so similar. Glycogenolysis is going to break down glycogen in order to produce glucose. And finally, it's going to have a role in breaking down lipids or increased lipolysis. And basically, thyroid hormone is going to act by steroid hormone mechanism. So it's going to go and bind onto an intracellular receptor and activate transcription factors, enters the nucleus, and then it'll transcribe specific genes. So I have another checkpoint here. Does anybody have questions?
No questions, thank you.
No questions. Okay. So I'm gonna say that let's take a 5-minute break because the rest of the session is a little bit heavier. So we're gonna take a 5-minute break and then we'll come back at 7:50. Okay. We're gonna start off where we left off. So we just talked about the synthesis of thyroid hormone, and now we're going to talk about the effects of T3 and T4. So thyroid hormone is really important in all parts of your body. It acts on virtually all the cells and body tissues. So what tissues are we going to discuss? What effects are we going to discuss? I briefly summarized the functions of the thyroid hormone and the effects of the thyroid hormone with the 6 Bs, but we're going to go over them in a little more detail. So first, we're going to talk about the cellular effects and how the thyroid hormone actually binds onto its receptor and does its job. And then we're going to talk about the cardiovascular effects and the effects it has that are metabolic, so effects on BMR and thermogenesis. And thermogenesis just means making heat. And then we're going to talk about the respiratory effects. And we're going to talk about the musculoskeletal effects, CNS, and the effects on our reproductive system, and the role that it has in growth and maturation. So let's start talking about the cellular effects. Thyroid hormone is going to act on all the cells and tissues in the body and the tissues, right? So what it's going to do is that it enters your cell via the monocarboxylate transporters, which we mentioned before, the MCT8 and the MCT10. And what's going to happen is that in the liver and the kidney, it's going to be converted into T3 via type 1 deiodinase. And in the brain, it's going to have its special deiodinase, which is type 2, so D2. Now, how does it act on your cells? Once it finds its way into the cells and it's deiodinized into T3, it's going to bind onto a nuclear receptor. So a receptor on the nucleus of the thyroid cell. And what it's going to do is that this receptor is going to start activating transcription factors, and it's going to initiate mRNA transcription. So RNA is going to be transcribed, and then it's going to be translated in order to produce new proteins. So it could be enzymes, they could be to increase cell function. Now, all of these are going to affect cell function. Now, the thyroid hormone has a lot of direct actions, but also acts in more subtle ways in order to increase the actions of other hormones via and neurotransmitters. So those are the cellular effects of thyroid hormone. How about the cardiovascular effects? Now, I have a picture here of a guy who has his heart fluttering. So I hope this helps you to remember the cardiovascular effects of the thyroid hormone. Basically, the thyroid hormone has a stimulatory effect. It has stimulation on the heart. So it'll increase lots of things in the heart. It'll increase contractility. It'll increase the speed of contraction. It'll shorten the diastolic relaxation time. So it'll do a lot of things in order to increase the power of the heart, make the heart beat faster and stronger. And how does this happen? It happens indirectly. And this is caused by an enhanced response to catecholamines, so epinephrine, norepinephrine. And basically what happens is that the increased response to catecholamines is going to increase the resting heart rate and the stroke volume. And if you remember the formula, stroke volume multiplied by heart rate is going to give you the cardiac output. So in turn, the cardiac output is going to also increase. Also, the thyroid hormone is going to have a positive inotropic and positive chronotropic effect. Inotropic means that it's going to increase the contractility of the heart, and chronotropic means that it's going to increase the speed of the contractions. Now, also, it's going to have a positive lusotropic effect. And lusotropic means that the diastolic relaxation time is shortened because the heart is beating faster. So there's less time for the diastolic relaxation time. So systolic blood pressure, in this case, is increased, and diastolic blood pressure is decreased. And this is what the effect of the thyroid hormone has on your blood pressure. And it'll also have increased pulse pressure due to your increased stroke volume as you took in CVP, and a reduction in the systemic vascular resistance because there's blood vessel dilation in the skin and the muscle in the heart. Now we're going to have a second part to the cardiovascular effects, the direct effects. Now, like we said, it had an indirect effect via the enhanced response to catecholamines, but it's also going to have a direct effect. Now, the direct effect, or the inotropic effect, which is increased contractility, is going to result from increased alpha myosin heavy chain expression and inhibition of the plasma membrane NCX. Okay, so here you're going to have increased myosin heavy chains. You can see the heavy chains here. And you're also going to have decreased NCX. Also, you're going to have increased sarcoplasmic reticulum ATPase, so circuit 2. It's not shown in this diagram, but you're going to have increased circuit 2. It's increased by T3, and you're also going to have decreased phospholamban, also not showed here. And as a result of these two things, so you have increased sarcoplasmic reticulum ATPase and you have decreased phospholamban, you're going to have increased and enhanced sequestration of calcium by the sarcoplasmic reticulum during diastole, and that will shorten the relaxation time. You're also going to have increased ryanodine receptors in the sarcoplasmic reticulum, which causes calcium to be released from the sarcoplasmic reticulum during systole. So all of this together, it allows an increased inotropic, chronotropic, and lusotropic effect on the heart. Now for the metabolic effects. The metabolic effects are basically, I summarized BMR and thermogenesis into one word, metabolic effects. And sorry, I made a mistake here. It should not say that. I'll fix that later. How does it have this effect, like this metabolic effect? What it does is that it acts on multiple things. It acts on the GI tract, it acts on the adipose tissue, acts on protein turnover, metabolism, thermogenesis. All of these things are acted upon within this production of the thyroid hormone. So in the GI tract, what happens is that T3 is going to increase glucose absorption from the GI tract and glucose turnover. So increase glucose uptake, oxidation, and formation. And remember how we said that it's going to also have increased gluconeogenesis and glycogenolysis. So basically what thyroid hormone does is to increase glucose levels in your blood. Also, in adipose tissue and fat tissue, T3 will increase the synthesis of fatty acids, and it'll also increase lipolysis. So it's going to increase the breakdown of fats. And also, it's going to increase the amount of protein, so protein turnover, which means more amino acids, more protein degradation, more protein synthesis, and urea formation. So a lot of protein synthesis and degradation is going to happen as a result of thyroid hormone stimulation. And for metabolism, for the metabolic effects, T3, thyroid hormone, is going to potentiate, or in other words, increase the stimulatory effects of catecholamines like epinephrine and norepinephrine, and also glucagon and cortisol and growth hormone. And it's going to increase the following processes. So it's going to increase gluconeogenesis, so it's going to produce more glucose, increase lipolysis, so increase the amount of fatty acids, increase ketogenesis, so it'll increase the amount of ketone bodies, and proteolysis, so it'll decrease the amount of proteins. It'll break down more proteins into amino acids. Then we have the point about thermogenesis. Now, you can't live your life without having heat in your body. Heat is necessary for all the enzymes in your body to work, so that your enzymes are not denatured, so your enzymes are not slowed down. They have to be at a heated state, right? You can't be hypothermic or hyperthermic, right? So thermogenesis is responsible for heat production. And what it's going to do is that thyroid hormones are going to stimulate thermogenesis by affecting ATP usage and the efficiency of ATP synthesis. So it's going to upregulate ATP usage using the sodium potassium ATPase and also the sarcoprotein, especially in calcium muscle, where in skeletal muscle where calcium is used and cycled between the sarcoplasmic reticulum and the cytoplasm. And it's going to generate heat and use ATP. Okay, so thermogenesis happens by increasing the usage of ATP, and ATP, when it's broken down, it releases heat. And this heat is important for thermogenesis. If you remember in mole, you lost some of the energy when you were doing your ATC, so some of that energy is lost as heat as well. Now let's talk about the respiratory effects. So what are the effects of thyroid hormone on our respiratory system? Well, basically, like we said, thyroid hormone, it has the mission basically to increase everything in your body. It increases your heart rate, it increases the amount of glucose in your blood. It just likes to increase everything. So what it's going to do also is that it's going to increase your oxygen usage and enhance your oxygen delivery. So it's going to stimulate utilization of oxygen and enhance oxygen delivery. So this will also help to increase the resting respiratory rate, the ventilation and the ventilatory response, to increase levels of carbon dioxide and decrease levels of oxygen. So thyroid hormone is important for using oxygen and delivering oxygen and increasing respiratory rate, and ventilation. And all of these actions of thyroid hormone are important in order to maintain a normal arterial PO2 when you need more oxygen, and also a normal PCO2 when carbon dioxide is being produced more in your body. And also, it's important to note that respiratory effect, one of the respiratory effects is that the hematocrit of your blood increases a little bit just to increase your oxygen carrying capacity. So this will result also from the stimulation of erythropoietin, which is produced by the kidney. Now you have the musculoskeletal effects, and basically the effects of thyroid hormone on the musculoskeletal effects will increase two things and decrease two things. It'll increase gluconeogenesis and glycogenolysis because, again, thyroid hormone likes to increase everything. So it also increases glucose in your muscles to give it more energy. And they also reduce glycogen and creatine phosphate. So it makes sense that they reduce glycogen, but why creatine phosphate? If you look at a resting muscle, okay, you have ATP and creatine. When they come together, they make creatine phosphate. This creatine phosphate acts as an energy reserve within the resting muscle. And whenever when your muscles are running low on energy, so for example, when you're exercising, when you're running, and you can't find any more energy in the muscles, you're using up and depleting your ATP reserves too much. The creatine phosphate is going to be broken down again by creatine kinase into creatine and ATP. And this will give you energy for muscle contraction. So thyroid hormones are going to increase your gluconeogenesis and glycogenolysis, and they're going to decrease your glycogen because they're increasing glycogenolysis, and they're also going to reduce your creatine phosphate. Now the effects it has on the CNS. Again, I made a mistake here that should have been deleted. So how does the thyroid hormone affect the CNS and its effects? Basically, thyroid hormone, it plays a very important role in the growth of the brain and the cerebellum, and the increasing the size of the axons and the branching of the dendrites and the production of synapses, and also myelination and cell migration, so neural crest cell migration. And thyroid hormone, if there's a deficiency while the child is still a fetus and in the mother's uterus, or if the child is in his early infancy, this will cause an inhibited growth of the cerebrum and the cerebellum, and it'll also cause decreased amounts of axons, synapses, dendrites, myelination, and all of those will cause neurological deficits in the child. So thyroid hormone in an adult is important for wakefulness and alertness and responsiveness. So if a person has lower levels of thyroid hormone, so they might not be awake or alert, they're going to be sleepy all the time. However, if they do have a lot of thyroid hormone, what's going to happen is that they're going to be irritable and angry, and they're just not going to be in a good mood. So the thyroid hormone is important in regulating wakefulness and alertness, and also memory. And the importance of having normal levels of thyroid hormone is to have normal emotional responses. And like we said, it has an effect on the child in the uterus. So if the child has a thyroid hormone deficiency in utero, they're going to have inhibited growth of the cerebrum and the cerebellum, and this is going to cause neurological deficits as the child grows older. And in adults, it's responsible for wakefulness and alertness, and also responsiveness to some stimuli. And if there's too much thyroid hormone, it can cause a person to be always awake all the time, having trouble sleeping, being irritable all the time. And if they have too little, then they're going to be sluggish and sleepy and tired all the time, and have a bad memory, and so on. Okay, so now let's talk about the effects it has on the reproductive organs. Whoops. What do thyroid hormones do in the reproductive organs? Basically, they're important in maintaining the normal ovarian cycle of follicular development. for maturation and also ovulation. So they're very important in maintaining the normal ovarian cycle. And you'll notice that in women who have hypothyroidism, they're going to have amenorrhea, which means that they're not going to get their periods. And this is because of the important role that thyroid hormones play in maintaining the normal ovarian and menstrual cycle. And in males, it's also important for maintaining testosterone levels. And it's also important for spermatogenesis. And all of the things that are like affected by the thyroid hormone can be disturbed if the levels are not in the normal range. And finally, we are going to talk about the roles of thyroid hormone in the growth and maturation. So again, this is a mistake. I don't know why it's added on to every slide. But a small amount of thyroid hormone is going to cross the placenta within the fetal life, and the fetal thyroid axis is going to be functional at mid-gestation. And this is really important for the fetus's neurological development and proper bone formation in the fetus. So, like we said, the brain and the bones are going to be formed with the help of thyroid hormone. And it also promotes linear bone growth and maturation of the epiphyseal bone centers. So the epiphyseal bone centers, or the epiphyseal plates, are the plates between the middle of the bone, not the middle of the bone, but the end of the bone and the cartilage area. And that epiphyseal plate will grow as the child grows. And then at some point in life, it's going to close off and become bone. So it starts off as cartilage and then it'll become bone towards the end of the child's puberty. And thyroid hormone is important in the maturation of epiphyseal bone plates. T3 is also going to enhance the maturation and the activity of chondrocytes. So during postnatal growth, T3 is important for actions of growth hormone and other growth factors. And also in adults, like apart from children, it's also important for normal bone remodeling. And bone remodeling, I think you took this. I don't think you took this yet, but bone remodeling basically means that as you go on in life, many small fractures happen in the bones and they need to be fixed so that your bones don't fall apart. So bone remodeling basically means that the bones are going to be broken down and then refilled in by osteoclasts and osteoblasts. So osteoblasts are going to fill in the holes that are left by osteoclasts. And that's going to be happening by thyroid hormone. And finally, tooth development and eruption. So when the children, they have their teeth developing and then they come out of their gums, it depends on the thyroid hormone. And patients who have small amounts of thyroid hormone and they don't have enough thyroid hormone are going to have something called congenital hypothyroidism, which will have irreversible intellectual disability. So they won't be able to learn as quick as their peers, and they're going to be very short because of the effects that it has on bones. Now here's another checkpoint. Do you have any questions?
No, all clear.
No questions. Okay. Now let's talk about thyroid disorders. Now, thyroid disorders can be divided into two groups, either too much thyroid hormone or too little thyroid hormone. Too much thyroid hormone will be hyperthyroidism. So hyperthyroidism, too much thyroidism. And an example of this is Graves' disease, which will have something called thyrotoxicosis as part of Graves' disease, but I've put them as two separate points. And too little thyroid hormone will be hypothyroidism. And an example of this is going to be Hashimoto's disease. Now let's talk about hyperthyroidism. Now, the most common form of hyperthyroidism is going to be Graves' disease. And Graves' disease is simply just an autoimmune disorder in which the body produces autoantibodies against your own TSH receptors. So this antibody is going to be called the thyrotropin receptor antibody, and it's produced against your TSH receptor. And when this antibody interacts with your TSH receptor, it's going to stimulate it. okay? And this will cause the stimulation of T3 and T4 production, as well as the increased size of the thyroid gland. Because when TSH stimulates the thyroid gland, like we said, the size of the follicles get bigger, the cells get bigger, so that causes an increased size of the thyroid gland. And these patients will usually present between the ages of 20 and 50, and it's 10 times more common in women, so you're going to more likely see Graves' disease in women. And you're also going to see a diffuse smooth goiter as a result of hyperplasia and hypertrophy of the gland, okay? So hypertrophy and hyperplasia of the gland, like we said, due to increased activity of the TSH receptors. So what does a diffuse or smooth goiter mean? A diffuse goiter is basically an increased size of the thyroid gland, but if you put your hands on it, it's going to be smooth. It's not going to be nodular, okay? So this would be an example of a Graves' disease goiter, so it's diffuse goiter. And here it's a nodular goiter. If you put your hands on it, there's going to be like hard, fluid-filled or solid nodules. And in Graves' disease, patients will be in a state of thyrotoxicosis. And thyrotoxicosis simply means that they're going to have way too many thyroid hormones in their blood and in their tissues. Now, the pathogenesis, I've already discussed it, but basically you have an autoantibody called thyrotropin receptor antibody, TRAB, and it acts like TSH, so it's going to overstimulate the thyroid. It'll cause an overproduction of thyroid hormone, and this is called hypothyroidism. And by negative feedback, this increased level of thyroid hormone is going to go act on the pituitary, and TSH levels will drop. So in Graves' disease, what you're going to see is that you're going to have high levels of T3 and T4, but low levels of TSH because of the autoantibodies. And here are some common signs and symptoms. So these patients who have Graves' disease are going to be way more anxious. They're going to be irritable. They're going to have heat insensitivity. Because if you remember, one of the functions of thyroid hormone was thermogenesis. So they're going to be always hot and sweaty and warm, and they're going to have moist skin. They're also going to have an increased level of metabolism. Remember the increased sodium, potassium, ATPase. So they're going to have weight loss despite eating normally, not decreasing their food. They're also going to have a goiter, so a diffuse goiter. They're going to have tachycardia, so a rapid, or not tachycardia, but palpitation, so rapid or irregular heartbeats, because of the positive chronotropic and inotropic effects that thyroid hormone has on the heart. And they're also going to have bulging eyes. And this is called exophthalmos. And we're going to talk about that later. But exophthalmos is basically caused by the proteinaceous deposits behind the eye that happen as a result of Graves' disease. And they're also going to have something called pretibial myxedema, which we're also going to discuss later. Now, thyrotoxicosis is simply the state of having excessive thyroid hormone in the blood and tissues. And a patient who has thyrotoxicosis is generally going to have a large increase in their BMR. So it means that they're going to have faster metabolism, and that will lead them to have weight loss despite increased food intake. Now, we've already discussed all of this. They're going to have increased heat production and sweating and greater intake of water. They're going to have increased heart rate due to an increased adrenergic effect. And they're going to have muscle weakness and tremor and nervousness. And they're also going to have oligomenorrhea, which means that they're not going to get their period as often. And they're going to have something called a wide-eyed stare, which is the, what was it called? The exophthalmos. So, they're also going to have thick, patchy skin, red skin, usually on their shins or the top of their feet. And they're going to have sleep disturbances also. And the most common cardiovascular sign is sinus tachycardia and increased cardiac output. Now, the treatment of thyrotoxicosis. First, how do we diagnose thyrotoxicosis? First of all, we carry out a thyroid function test. So we test levels of serum T3 and T4 and TSH. If T3 and T4 are high and TSH levels are low, then this is what's going to tell you that the patient has thyrotoxicosis. Now, how do we treat it? We treat it using anti-thyroid drugs like methimazole and propylthiouracil, and those are going to block the thyroid from making hormones. And then you're going to have another treatment is where you give them radioactive iodine by mouth. And basically, when they eat this iodine, it's going to enter the blood, it's going to be reabsorbed, going to be absorbed in the GI, and then it's going to enter into the blood, and then it's going to find its way to the thyroid. And when it finds its way to the thyroid, the cells, the overactive thyroid cells, are going to absorb this radioactive iodine, and this is going to damage the cells. So the cells are going to atrophy, they're going to die, and the thyroid hormone levels are going to drop. And this usually leads to like permanent thyroid destruction, and then that later on causes hypothyroidism. And there's also a surgical removal or surgical resection of the thyroid gland, which we call thyroidectomy. And usually they do something called a subtotal thyroidectomy, which means that they don't remove the entire thyroid gland, they leave some parts because they don't want to remove the parathyroid glands as well. And this is going to correct hyperthyroidism again, but it might also cause hypothyroidism because you no longer have a thyroid tissue. Now, hypothyroidism from the treatment of hyperthyroidism can easily be treated by hormone replacement therapy. Now let's talk about hypothyroidism. And hypothyroidism is three types. You have primary, secondary, and tertiary. Primary hypothyroidism is caused by the thyroid gland itself failing, and this is the most common kind of hypothyroidism. Then you have a secondary hypothyroidism, which is when the pituitary itself causes reduced TSH. So pituitary is not stimulating the thyroid gland, but the thyroid gland itself is intact. Now the final type is tertiary, where the problem is in the hypothalamus. So the hypothalamus is not stimulating the pituitary, so it's unable to stimulate the thyroid gland itself. Now, in primary hypothyroidism, T3 and T4 levels are abnormally high and TSH is high. Why? Because in primary hypothyroidism, the thyroid gland itself is not working, so it cannot produce T3 and T4. So the pituitary gland is going to try to compensate by increasing levels of TSH in order to stimulate the thyroid gland, even though the thyroid gland is not working. So you're going to have high levels of T3 and T4, but low levels of TSH. Then for secondary and tertiary hypothyroidism, both of these, you're going to have both levels of the thyroid hormones are going to be low because the thyroid hormone is not getting the stimulation that it's needing, and TSH levels are also going to be low. Now, I think I've already pointed this out before, but if hypothyroidism happens while the baby is in utero, so in his mother's uterus, or if the baby's in early childhood, this can cause something called congenital hypothyroidism, which used to be called cretinism, but now it's not cretinism. And it's most commonly caused by an iodine deficiency. And affected people will have severe intellectual disability, short stature with incomplete skeletal development, and coarse facial features and a protruding tongue. So those are the features of people who have congenital hypothyroidism. Now let's talk about Hashimoto's disease. Hashimoto's disease is also an autoimmune disease, but it's a disease that's found in people who are not iodine deficient. So hypothyroidism can be caused by iodine deficiency, and it could also be caused by an autoimmune disorder. So hypothyroidism in adults who are not iodine deficient will usually be caused by Hashimoto's disease, and this was previously called lymphocytic thyroidosis. And the pathogenesis of Hashimoto's disease is that basically you're going to have autoantibodies again. But in this case, the autoantibodies in Hashimoto's disease are going to be directed against peroxidase. And if you remember who peroxidase was, he was our clownzyme, the one who was responsible for OOC, oxidation organification coupling. So if the thyroid antibodies, autoantibodies, are directed towards TPO, then you're not going to have formation of thyroid hormone, right? And they could also be directed against thyroglobulin or the TSH receptor. And in the end result of this is that it causes apoptosis of the thyroid cells and the cells of, or the follicles of the thyroid to be destructed. And that will cause a huge reduction in the ability of the thyroid hormone of the thyroid to release thyroid hormone, and it can cause goiter, but it's not always seen. So how do you diagnose hypothyroidism? You'll find low levels of T3 and T4 and elevated TSH, and the elevated TSH could lead to goiter, but also, again, not all the time. Now let's talk about mixed edema. And basically, mixed edema is a severe hypothyroid state due to thyroid failure. And basically, it's diagnosed with TSH and T4 tests. And the symptoms of mixed edema will include reduced metabolic rate, dry skin and sparse hair, hypothermia and swelling in the face and the legs, goiter, as well as low blood pressure and heart rate, confusion and decreased breathing, and also accumulation of negatively charged polysaccharides in connective tissue, which attracts water and sodium. This could lead to swelling of the face, the tongue and the lips, and the preorbital edema. So mixed edema could cause exophthalmos, which means that the eyes are protruding outwards. And I had a picture of exophthalmos here. This is exophthalmos, when the eyes are protruding outwards. And this is caused due to periorbital accumulation of fluids and proteins. Polysaccharides in connective tissue. And then also mixed edema will cause a non-pitting edema in the lower extremities, and it'll be associated also with skin thickening and discoloration. And it's also treated with a replacement T4. Now, something called mixed edema crisis is when the body can no longer tolerate all the changes caused by severe hypothyroidism, which leads to the decompensation and requires immediate medical attention. Now, along with the symptoms of severe hypothyroidism, the symptoms of mixed edema crisis can include respiratory depression, so decreased breathing, hyponatremia, hypothermia, confusion or mental slowness, shock, low blood oxygen levels, high blood carbon dioxide levels, seizures and coma, and mixed edema crisis can usually cause death or complications from infection and bleeding and respiratory failure. And the summary here is you have the difference between hypothyroidism and hyperthyroidism. Hypothyroidism will have cold intolerance, decreased sweating, weight gain, constipation, irregular and heavy periods, brittle nails, puffy face, muscle or joint pain, slow heart rate, depression, and irritability. So basically everything in hypothyroidism basically slows down. However, in hyperthyroidism, you're going to have weight loss. You're going to have short and light periods. You're going to have puffy face and bulging eyes, racing heart, diarrhea, heat intolerance, muscle weakness, nervousness, and anxiety, nail thickening and flaking, increased sweating, exophthalmos. All of these things are going to be found in hyperthyroidism. So everything speeds up in hyperthyroidism. Now, if you look at the things that they have in common, you're going to have fatigue, insomnia, and hair loss. Now, here's another checkpoint. Do you have any questions?
No questions.
Okay. Now I have a few questions that we can solve together. So if you guys want to answer these questions, it'll be helpful for you and I can explain them. Now, a 30-year-old woman reports to the clinic for a routine physical examination. The examination reveals she is pregnant. Her plasma levels of TSH are high, but her total thyroid hormone concentration is normal. Which of the following best reflects the patient's clinical state?
They're saying C.
Okay, it's not C. Try again.
Is it B?
It's B. Yeah. Okay. So basically, let's look at the explanation for the answer. Now, since there's negative feedback, remember how we said that there's negative feedback from the plasma levels of TSH. So there's negative feedback. So this is going to cause high plasma levels of TSH are going to indicate very, very low levels of free thyroid hormone in the circulation. So total thyroid hormone concentration is normal. They didn't mention the free thyroid hormone. The free thyroid hormone is going to be less, and that's why you're going to have increased TSH, because you don't have enough free circulating thyroid hormone. All right. And that's why the answer is going to be B. The answer can't be Graves' disease because TSH levels are high and TSH levels are low in Graves' disease. It can't be a pituitary tumor secreting a TSH, but I understand why you would say that. But in that case, then the total thyroid hormone level would be low because you wouldn't have enough thyroid hormone being secreted because no, sorry, a pituitary tumor secreting TSH, you'd have high levels of thyroid hormone because you'd have increased levels of TSH and increased levels of thyroid hormone. It wouldn't be D because it would also have the same end result as C. And the patient is not taking a thyroid extract because if she was taking a thyroid extract, then she would have high levels of thyroid hormone. Does that make sense? Okay, I'm going to assume it makes sense. Now let's move on to the next question. A patient has a goiter associated with high plasma levels of both TRH and TSH. Her heart rate is elevated. This patient most likely has which condition? Have you found the answer yet?
Is it B?
It's B. Good job. Yes, it's B. Do you want to tell me why it's B?
Okay, so they said that TRH and TSH both have high levels. So TRH would like stimulate the release of TSH. So it has to
Yes.
start from the hypothalamus.
Exactly. Good job. Now, one last question. A patient presents with tachycardia and heat intolerance. You suspect Graves' disease. Which of the following is not consistent with your diagnosis? Have we got the answer yet? Okay, so if you haven't gotten the answer, it's okay. I'll answer it. Just let me know.
Yeah, no answers.
Okay, so the answer is E, and let's explain why. Now, Graves' disease, like we said, it's a hyperactivity, it's hyperthyroidism, so increased levels of thyroid hormone, decreased levels of TSH. So increase in total free T4, that is consistent with your diagnosis, so it can't be A. Suppressed plasma TSH, that's also consistent with your diagnosis, so that can't be the answer. And you'll often see an exophthalmos and goiter with your Graves' disease, so those also cannot be the answer. So the only one that's not consistent with your diagnosis is decreased thyroid radioactive iodine uptake. And if you remember, one of the treatments for one of the treatments for hyperthyroidism was radioactive iodine. So when you give the patient radioactive iodine orally and then you wait for it to destroy the thyroid cells and to cause essentially hypothyroidism in the patient. So this is the only answer that is actually consistent with your, not consistent with your diagnosis. And that's the explanation of the answer. And thank you so much. My name is Malak Hassan. I'm a second year medical student. And please feel free to ask me any questions that you have. This is my email and that's my number. And yeah, thank you so much for listening. Thank you for those who attended. And have a nice day. And yeah, please scan the code. Where is the code? Okay. I'm sure I added the code. Hold on. Here's the code.